Subscribe to our channel now and press the bell icon to never miss an update from KIMS Global.
Hi, I'm Dr. Khalil Isaac. I'm a senior consultant in neurosurgery and I'm working at KIMS Trivandrum. Advancements in tumor surgery have been more linked with precision than with anything else. Today, all brain tumor surgery is conducted under a microscope, under high magnification, and the surgeon generally has full control on what he resects and what he leaves back. So, precision in surgery allows the surgeon to remove maximum amount of tumor without producing a major deficit. Stereotaxy is a method wherein we can localize a tumor which is in the depth. In stereotaxy, you take X-rays in 3 coordinates, X, Y and Z axis, and this helps you to localize a tumor in the depth. Another modality which is now widely used and which is of great benefit to a tumor patient is neuronavigation. Neuronavigation provides a surgeon with real-time information on where his instruments are in relation to the brain and to the tumor. For this, you have to understand that there is someone or something, usually an optical sensor, that is tracking the instruments in your hand. On the screen, you also have an image of the brain and the tumor. The computer superimposes the position of your instrument to where the tumor is. This way, you get to know as to whether you are in the limits of the tumor, where you are in relation to deeper structures, and whether your resection is complete. We also have an imaging modality called intraoperative MRI. Intraoperative MRI is an MRI machine inside the operation theatre complex. However, this involves a lot of logistic headaches because instruments which are used in the vicinity of an MRI machine have to be MRI compatible. They should not get dragged onto the magnet. So intraoperative MRI suits are available and they can tell you in between a resection as to whether you have completed a resection or not. It has utility, but very few centers in India are currently using it. Radiation, new modalities have come in. I already mentioned gamma knife and stereotactic radiosurgery. In gamma knife, for example, a person's head is exposed to radiation but is protected from radiation also by the use of a helmet. Now this helmet has got about 250 odd openings through which radiation can enter. The computer decides as to which of these orifices are to be kept open and which are to be kept closed. So we have intersecting beams coming in a gamma knife which will damage the tumor and damage little else. That is the whole principle of gamma knife and also of stereotactic radiosurgery. Chemotherapy, the bugbear is the blood-brain barrier. It saves the brain from noxious influences, and also it keeps out many of the chemotherapeutic drugs, so usually used as an adjunct to surgery. In surgery, one of the other adjuvants which we use is something called fluoroscopy, where a tumor can be made to light up by the injection of certain dyes. And there are also some dyes which can pick up laser beams selectively. So by using these porphyrins and then using a laser to ablate, you can damage tumor cells without damaging the surrounding tissue. However, these are all experimental and full applications of this are not yet proven to be of clinical benefit. Robotic surgery has been used in neurosurgery, and probably one of the first robots in medicine was a Puma arm which was used for stereotactic brain biopsies. However, robotics real-time, like in a Da Vinci system, they use for cardiac or prosthetic surgery, is not being used in the brain because somehow we still need the tactile feel and our experience which is located in the vestiges of the neurosurgeon's information repositories to make the best decisions during surgery, including tactile feedback, which is very important during surgery.